Okay, so don't forget, if you've got questions, pop them in the chat and we'll make a start. And Kirsty, if you could start recording. Yeah, that's going fantastic. So we're talking this morning around the Reasonable Adjustments digital flag. We have myself, I'm going to do a really quick overview of the Reasonable Adjustments campaign to bring people up to date and make sure you know where all of those resources are. We've then got Hannah, Dr. Hannah Brown, who's going to give us a presentation, including some of the stuff that's happening nationally. Darren McKenna is going to give us an overview of some of the digital elements of the app, bearing in mind if people have very specific questions around digital, it might be worth answering those individually, but we'll work out that when we get to questions. And then we've just got some final comments and we'll let you know sort of what's happening next with the work. So as far as the Reasonable Adjustments campaign is concerned, the Reasonable Adjustments campaign we launched back in June. This is a way of us starting to raise that awareness of reasonable adjustments with both the health and social care workforce and the general population. We were very aware from conversations with people and through our experts by experience that people struggle to understand what reasonable adjustments are, where they're entitled to and how to ask for them. So this campaign has been around trying to increase that awareness. The campaign itself is fronted by people from the North East and North Cumbria, so they are all local people who live and work within our area. And that's been really lovely to be able to engage those people to help us with the campaign. So you may recognise some faces. So the campaign has those two elements around raising awareness of people's rights for reasonable adjustments and those legal obligations for health and care services, but also to support the health and care services in understanding and providing reasonable adjustments. And as I was saying before, also support those service users in understanding what those reasonable adjustments are and how and when they can ask for them. The resources look a little bit like this, and the colour coding, so the resources are all colour coded for specific groups. So the orange colour is aimed at social care, the blue is at service users, and the blue service users, and the purple is healthcare. And that's because we've just had some specific messaging. These are the main poster style, and then on each poster there's a QR code, and that QR code takes you through to the website where you can get further information and more resources. So this is an example of what the website pages look like, and then those additional resources that can be got through the website. We have had a limited amount of stuff printed, which has pretty much gone out and been distributed to through a lot of our contacts. But if you wanted to arrange and get stuff printed, you are very welcome to take the versions that you can find on the website, or get in touch with us directly if you need high quality versions, and we can help you get stuff printed if that's what people feel is going to be best for them. I just wanted to show this. This is an example of one of the resources that you can get off the website. It's an A5 card, and this is an example of a resource that an individual could have with them personally. On the front, it gives a little bit of information around reasonable adjustments, and then on the back there's that opportunity for a person to individually record what their reasonable adjustments are, so that they can show that to whomever they're making contact with within health and social care, to make sure that they're aware of what their reasonable adjustments are, and hopefully they can be fulfilled for that individual at that appointment. This also is in a credit card size. We're just trying to give people those resources to start that conversation, because we're very aware the flag is not up and running as yet across our systems. So we need to give people those resources to start the conversation, and this is examples of those. The Reasonable Adjustments campaign links to a number of other pieces of work that the North Eastern Cumbria Learning Disability Network are doing, and this is an example of one of them. This is the Prevention of Adult Not Brought strategy, and when we share the slides later, the links through to the strategy are within the slides. So if you just click on the picture, it will take you directly through to that strategy. And we find that in a lot of the work that we are doing, it links back to reasonable adjustments and the reasonable adjustments flag. So you may find that when you're hearing the presentations today, you're not directly working on a reasonable adjustments flag, but you're like, oh, but that links with this piece of work that I'm doing, or it links there. And so I think you'll find very clearly that you can see how it links very much into different people's roles and the projects that they have. I'll come on to next steps a little bit later. So let me just stop sharing there. And Hannah is going to present next. But if anybody has any questions just on those few slides before I pull up Hannah's presentation. I don't know if you want to raise a hand or pop in the chat. Very aware that's more for information around the campaign. Brilliant. Okay, so I'm going to share your slides, Hannah.
Perfect. Thank you, Julie. Morning, everyone. Thank you so much for giving me the time to talk about the flag. As Julie so correctly says, this is about linking all of these really, really important pieces of work that require us to understand what reasonable adjustments people need. And I think the really key word in all of that is the reasonable. And we forget that this is just about being fair. Next slide, please, Julie. Thank you. So what this basically comes down to is the really simple thing about, it's not moving for me, Julie, is it moving for you? Oh, there we are. Lovely. For equity, not equality. Everybody has equitable access to services. That's how it works, but it's not the fair access. And equality and equity are very different things. Left-hand side, everybody's got equal access, but it's not the fair, equitable access, which we can only do by making changes to make sure that everybody can see and do what they need to access services, both in health, social care, but absolutely everything. And they're a legal requirement. So it's not so much that it's about just doing the right thing. We should have been doing this since 2010, and the Equality Act put this in statute of law. It can be really complicated things like redesigning big services, but really simple things like having a carer with you, making sure you've got a longer appointment, providing easy read information. And it's about making the changes for the single person in front of you to make sure that they can get the care that they deserve in a fair way. The reason behind all of this, and I appreciate that some of you will have already know all this or have heard this in previous talks, so I apologise for repetition, but I think it's a really important point, is that this came out of several pieces of really important work. First, in 2008, a Healthcare for All paper identified that people with learning disabilities had a vastly different experience of healthcare and a far inequitable one. That led to the Stakeholder inquiry, which found several different causes for that inequality. And one of the main ones was the lack of reasonable adjustments. And if they found that if we could make those changes, the difference to care that could be provided was quite marked. So as I say, the 2008 one showed that there was a significant difference. And the key point in my mind on this is that they are, whilst included in theory as equal citizens, without these equitable rights of access, and equal not being meaning the same, we're not giving them the same care and services as we should. So we need to make sure that we do provide this equitably. Julie. So as I say, we've got to make sure we make these reasonable adjustments. It's in law, it's been in law since 2010, but it isn't happening. And the main reason for this is because to make reasonable adjustments, you have to know what they are anticipatorily. You have to know and put them in place before the person finds they can't access their care properly. That's really difficult with disparate health and social care services as we've got in England. There are over 600 IT systems, for example. And if you think about how we communicate between all of those services, it's incredibly difficult to make sure that you get the messages across about what you might know for your patient's need to everybody else. The NHS long-term plan says that you have to have a flag on records for anyone with learning disabilities and autism. What about those adjustments? What about ensuring that you know what you need at every step? So the one thing that we do all have in common is the NHS spine. So what the NHS England team have done is build a flag on the NHS spine so that we can share that information. Originally, it was built in an entirely separate platform, and it was tested in 2019 down in the southwestern Devon area. And findings were, and I think my favourite phrase out of it is, well, this is a no-brainer. But the problem was that it wasn't just integrated in a way that meant it could be used. If it's in a separate system, the inability for us to be able to see what's on there without linking into that separate server is just going to restrict access. So we had to create an integrated system, and the use of that has now been written in and mandated by something called an information standard. This is a document that tells you what you have to do and is mandated by law under the Health and Social Care Act. And it requires us to start making those adjustments on our local records by March 2024 and embedding systems that allow us to record this information in a way that then can integrate with the flag as it becomes live next year. So as I say, there's two steps to this, and the reason for that, thanks Julie, the reason for that is that we know that what we need to do is put the information on our local system. So we know what our patients need. If I ask my receptionists tomorrow what, I'm making a name up here, Billy might need, they can tell me without even thinking about it what he needs, which is great. But what happens when he turns up in A&E in Middlesbrough? Or if he goes to an outpatient department he's never known about before? So what we need to do is find a way to put that information in a way that is easily transferable. And that's what we're asking organisations to do now. To make sure, and to be honest, most of us are doing this already, that we find out who needs those reasonable adjustments. And we know that that will be for a lot of people with learning disabilities and autism, and certainly for autistic people and people with learning disabilities, perhaps the difference in care is most marked, and evidence would suggest in previous leader inquiries that you are twice as likely to die from an entirely preventable cause if you have a learning disability, most of which is due to reasonable adjustment deficit. So we know that those are a huge group of people that we need to be targeting. But actually this applies to potentially up to 13.8 million people in the UK. So this is a very widespread project, and we're not expecting clearly for all of those people to have reasonable adjustments recorded on their records by the end of March. But what we are asking is for organisations to start this process, to find a system that works for them, to identify people that need reasonable adjustments, to record those. Sorry, Julie, could you go back a slide? Thank you. Thank you. To record using the local codes that you use, potentially on paper first, but then ultimately digitally. Flag it so that it's visible on your systems, whether that might be digital or whether that might be on your paper records, whatever you use day in, day out, so that everyone in your team can know that this person has reasonable adjustments and think about how you can put those in place for you. Sharing them in every communication. Already in the North East, due to the amazing work that's been done, we've got them on 2-week wait referrals, but share them on other things like on ICE referrals, on letters, on communications that you might be using with community teams. You do need to obviously make your best effort to meet the adjustment. The standard specifically doesn't talk about meeting adjustments because it's out with the digital component of sharing it, but clearly it's required in the Equality Act, and obviously it's common sense as well. But also review it. What we don't want is for people to be asked at every single contact every single time. So if they come into the practice, for example, 3 times in 2 weeks, being asked every time if they need reasonable adjustments defeats the object of having the flag. So once you've recorded those adjustments, putting that review code that we now have on as well will mean that people know that those are up to date. Clearly they can be changed as they go, but making sure that that review does occur, because what you need when you're 15 or when you're 5 and your mum's bringing you to appointments isn't the same when you're 25 and hopefully living independently. Your needs may change as your social circumstances do, but also as your physical needs do. So once we have all that information on our local systems, we can start to share it. And as Julie stated, what will happen is the flag will be starting to go live next year. You can only share information you've got on your local systems, but once you've got it, we'll be able to share it between all of those systems. It's, in my mind, always a little bit like if you've got photos on your phone and I've got photos on my phone, if we can connect them in via a linking system through a central saver like a cloud storage or a PC, then we can share our photos from to each other. So the simple thing here is about making sure that the information's in one place so we can go to the next. So how that works in from the point of view of the spine sharing, thanks Julie, is that, sorry, just wait for the next slide to come up. So thinking about the computer systems as a hub and sort of hub and spoke model. So the central spine in the middle has, let's just imagine 3 organisations attached to it, and the patient's going to contact those 3 organisations. And so we're going to say that A organisation is the GP surgery. So thanks, Julie. Organisation A will add some information onto the spine. They realise this person needs reasonable adjustments. They'll record that locally. They'll record consent to do so. That will then communicate directly up to the spine. When that patient then moves on to organisation B, they will see by the communication directly from the spine that this person has a reasonable adjustment need. So it's visible to them. So they get that information and they can see it. So they can see what organisation A have added. And that's likely to represent perhaps an A&E department or an outpatient department. Thanks, Julie. They might, however, whilst the patient's there, realise that they need to update information. There might be something they recognise that the patient needs that the previous organisation hasn't. So they will update that information back up to the spine. And then organisation C will then be able to see the information that organisation A and B have now added. So it's now up to date. It's got the most contemporaneous and appropriate information relevant for the patient at that point. So there are challenges, and we know that it is a big change to how we're working, but it isn't in many ways different to what we already do. We are already asking about information that might make somebody's access to local care easier. It's just about sharing it. So one of the questions we frequently get is about consent to this. So can I consent? Do I have to consent? Do I have to ask? And the simple answer to that is yes, you do. In the same way that we have to consent to share on things like the SCR or the local care records, we also have to ask if it's possible to share information on this. Our pilot testing has shown there's a very small minority, but an important minority of people who actually don't want most of their information shared, but would want their reasonable adjustment information shared. Actually, none the other way around so far, but that I'm sure would occur. So it is a consent and consult approach. And that there is therefore a code that you need to put in to say that consent has been achieved. Standard mental capacity rules and best interest decisions apply, and that's obviously particularly important for people who have got previous decisions that need to be considered. We need to consider training. Obviously, if we're talking about this today, but I'm aware that I'm not talking to absolutely everyone in the UK all in one go. So we are creating some resources, which I'll come back to later. We need to make sure we're talking to the right people in the right places. So we're doing a lot of stakeholder work, but I think it's really, really important that if you feel that we're missing people, they feel that we're not reaching certain organisations, certain patient groups, then we really need to know about that. Because as Julie said before, a lot of people don't actually know what the phrase reasonable adjustments means or what they're entitled to. I still find it quite frightening how few people appreciate that this is something that they are legally entitled to, rather than it just if we can. And then from a communications perspective, it's about reaching those groups. So again, if you feel that we're missing things, then please let us know. The resources that the NENC team have done here are absolutely fantastic. And I was very unsubtle about putting them all over the wall in the back of the videos that will be in the national training programme, because I think they are absolutely awesome. And they are genuinely the best that I've seen nationally. So they are fantastic. Please use them. And from the point of view of the technical challenges, I'm not going to get into great big details about this because Darren's going to cover this in a moment, but we are obviously facing, as I said, 600 odd IT systems across the country, multiple providers, multiple systems. But essentially what it comes down to is that suppliers are now mandated by law to ensure that this is compliant with your systems by June of next year. And we're looking at ways to make sure that that is easily rolled out as possible. So timeline wise, as I say, by the end of March of next year, organisations need to have systems in place. I'm not suggesting that everybody has every single patient, all of their reasonable adjustments recorded. That's clearly A, impossible, and B, also not representative of how we work. But if we can have systems in place that allow that every contact that you now have with patients as they come through, you start recording reasonable adjustments, we're increasing that data bank, we're increasing that knowledge base. By the spring of next year, we will have that e-learning that I alluded to before. So we're creating an e-learning package, which will have an explanation of what reasonable adjustments are, how you can put them into place, why it's relevant for you. And that will be on the e-learning, well, the new NHS e-learning hub, which is currently e-learning for health. And that's being developed with a huge amount, like all of this, with co-production with the patients and carers that are involved in this work. API testing is undergoing. So API is the application platform interface. It's basically the cable that I mentioned that connects your phone to your computer. I'm sure Darren's eyes are rolling at this stage, but I'm a very non-technical person. In my mind, it's about getting information from here to here. How do we do that and integrate with your systems? And that's what that's all about. But if we can get those flags being populated locally, that information can share. And by June of next year, we should have that information flowing backwards and forwards in that hub and spoke model that I mentioned. So just going back to this again, so just reminding us of that 6 steps that we need to do. What do you need to do where you are next? Thanks, Julie. So this is a very busy, very small typed slide. And the reason for that is because as I tried to type it, I tried to make it much more open, and then realized that that's the whole complexity of this. We are doing lots of these things already though, so it looks frightening, but I bet you that it's what you're already doing. So other things that you could consider apart from what you're already doing, which would be to ask people as you see them, is things like consider, could you put it on your new patient registration documents? Any recall, review, appointment letters, can you just put a paragraph in the middle of that just to say, if you have reasonable adjustments, please present these or ask us when you come in. And the same things for flu letters or any kind of annual cohort register that you bring people in. So the kind of texts that go out when we've sent our reasonable adjustment, our flu campaign texts out, we've just included a 1 sentence about that. Things like reviewing registers, but also any information that comes in from externally, things like referral letters or discharge letters, if you recognise that might result in a reasonable adjustment conversation, asking patients about those. Things from the point of view of recording, as I say, we are looking for that to be recorded digitally. It can only be uploaded digitally if it's recorded digitally. So if you record on paper in your organisation, please just make sure that some point somewhere along the line that's recorded digitally. And you can either do that if you are non-IT compliant, if you don't use your IT systems all day, every day, and lots of organisations don't, you can do that directly into the flag. If you are on an IT system, like in primary care all the time, we're looking at how we can create standardised templates for you, including with Ardens, and we've had some very productive conversations with Ardens who are going to create some templates for us, and we can share those with System 1 and EMIS, who will then be able to create their own as well. Key thing about flagging locally, as I say, make sure it's really visible where you are, and that's often going to be about pop-ups again with things like IT systems like System 1, EMIS, who are nearly finished writing their version, and Ardens, it will be immediately visible. You won't have to do it yourself. But if you use paper records, whatever sticky thing you want to put on the front of the notes or something that makes it obviously visible, or if you're in secondary care systems and you're using LD flags, can you add a reasonable adjustment one aligned with that kind of thing? And as I say, sharing through the systems that we've already mentioned. So from a national approach, that's what we're doing. That's what we're thinking. We're asking everybody to consider doing locally, or an overview of some of the ideas that you can do. As I say, we're trying to communicate right the way through the country, and that's from a regional dissemination approach. It's linked into lots of other learning that we've got, like the recent publication of Leader, but regular webinar and stakeholder events, I can never say that sentence, and raising awareness events like today. But the more that you can think of, the more that you think we need to be talking to, please let us know. Other potential avenues for training as well as the e-learning are being explored, including things like some summary short versions of this so that you can pick and choose which one you want to look at, and hopefully we'll have those created within the next few months for people to pick up and look at. And we're also creating an entire bank of resources, sort of best practice versions of, I mentioned things like letters out to patients and questionnaires. In my mind, if I wasn't involved with this, I'd need to know that I could just say, well, fine, but show me something I can use, rather than create my own one every single time. So we're creating a bank of resources on the NHS Futures platform and looking at other places to host those as well. The idea being that you could basically, a bit like a supermarket effect, just pick off, I need something for identification, I need something for recording, and just be able to pick off a resource that you can then use. So this is directly lifted from the standard and implementation guidance, but this is basically just the summary of the things that you need to do. Again, looks really frightening, but it's basically just what I've just said, with the exception of the word policy at the front. It's sensible to have a policy. It doesn't define what your policy needs to look like, how long it needs to be, but the key thing is that the people in your organisation need to know that they need to do it. But basically, it's then just an approach to identifying and recording, and a way to flag, a way to share, a way to review, and to make sure from your IT systems perspective that those clever people like Darren are aware of how to make the digital integration work where you are, and just ensuring that your staff know about it. Again, there's no defined way that you have to do the training, but just making sure that this is perhaps in briefings, or that there is a 10-minute conversation on the fact that this is occurring. As I say, the e-learning will be rolling out in March, but you might want to do something a little bit earlier, because clearly if you're trying to ask people to do this now, just asking them to wait until March for a full formal e-learning will just delay how much information we've got available to share. So just to finish off, as I say, this is about that equality and equity. Equality on the left-hand side, it's the same treatment, happy days, but that's not fair. Equity is what we're trying to achieve with the flag. Just trying to make sure that we reduce the barriers to care, to try and help people get at what they need to do in a fair and equal way that's just human as well as ethical, as well as legal. My ideal world will be on that right hand side at some point, but I'm also not stupid to think that we're going to manage that in time soon. So if we can at least get to the bit in the middle, that means an awful lot to me. Last slide is just the resources. Thank you. So there's the implementation guidance, and then just the actual website page for the flag itself. Both of those are obviously hyperlinked, but the QR codes for those as well, should you want them. Thank you very much.
Excellent. Thank you very much, Hannah. And I will just apologise for the slides that were jumping around. I'm not entirely sure why. I think there was a timer on them that I couldn't turn off. So apologies for that.
No, thank you for dealing with it. I didn't even know that was on there. Right. Well done, thank you.
Hey ho.
You managed brilliantly, thank you.
Does anyone have any questions specifically for Hannah at the moment? Or are we happy to move straight on to Darren, and then we can, after we've seen both lots of presentations, we can do those questions jointly, which I think will, yeah, I think that's going to work best. Just to say the couple of points that are in the chat, yes, we will share slides. So you'll have access to the slides. And the SNOMED codes, Kirsty has put the link through to the website, and the SNOMED codes can be linked from there. So, sorry, the North Eastern Cumbria Learning Disability website, and we've got a link through to the national page where you can find the SNOMED codes.
Sorry, Judy, can I just very quickly respond to that? So the review code and the consent code, they had to be requested new. So all the original RA codes, including the sort of reasonable adjustment required code, and all the standardised codes, for instance, needing care, etc. Those have been available for a while, and they all have mapped codes. We had to request specific consent and RA codes, and review codes, and So those have been approved and released over the summer. System 1 now have mapped. So I know System 1 have got mapped codes. I don't know about EMIS yet, to be honest. I think I think they have, because they've created their API servers. So I'm fairly sure that EMIS and System 1 have, but I will certainly give you I can link and put the SNOMED codes in the chat, but the mapped codes for your local systems will obviously be very dependent on your own specific servers.
Kathy, you've got your hand up. Is that relating to this question?
Yeah, thank you for that, Hannah. Amazing to hear what's going on as ever. I just wanted to say that I look at most days when I'm in the practice to see what's going on, and I still can't see a lot of this stuff in the templates that we use. And I guess you will probably have the first heads up.
Yeah. So
when that
those.
happened.
Yeah, absolutely. So those are all being developed at the moment. So we've got 3 sort of, if you like, first pilot IT systems that are building not only the templates but the API and piloting those. The 2 that are probably most relevant for this group are EMIS and Rio, and that means that we're covering a good selection of primary care, social care and mental health care. And they're testing their systems and are building their templates. They're still at kind of sort of wireframe stage, which is when it looks like what it looks like, and they're testing to see if it works on their own systems. But we're hoping in the early new year for that to be available right the way through the system. Ardens are dead keen to get theirs out ASAP, and they won't rely on EMIS and TPP. They'll just build their own. That will obviously, from an Ardens perspective, only about local coding, but that's all phase 1 is at this stage anyway. So if we can have a system that allows us to do that, and the benefit of Ardens, of course, from a primary care perspective, it covers 86% of the country. So I mean, if we can get that built there, that makes an enormous difference. So Rob and I, sorry, that's Ardens CEO, and I are trying to get that out within the next few weeks, but obviously it just takes a bit of time to build. But as soon as we can, I will let everybody know, because if it's available, people need to know it's there.
Thanks, Hannah.
Excellent, thank you very much. So Darren, if I could hand over for you, and again, we'll take questions after Darren's spoken for both Hannah and Darren. So Darren.
Yeah, fine. Are you driving the slides, Julia? Will I do my own? You got them there. Fab. The good news is I'm probably not going to get as technical as Hannah has done. So if we've got clinicians on the line, please don't switch off. I'm going to try and keep this high level, but give you sort of a bit more of an update around the digital and the system side of things. You got the next slide there. Brilliant. So just to sort of again highlight, we've had the information standards notice published, as Hannah mentioned, on the 12th of September. This is quite a key document in terms of working with your system suppliers, because this is generally sort of most of the information and instruction they need to go away and sort of start thinking about how they implement this. Also, the significance of information standards notices. People generally have these built into their contracts with their system suppliers. So system suppliers are effectively contractually mandated to meet and deliver these. It's not always the case, and there are sometimes a little bit of pushback from suppliers, but in a general sense, this is the lever we have to get the suppliers to deliver the functionality that we need. Just pop it on. I was just going to pick out a couple of the key highlights from the information standards notice. If you can just move to the next one there, Julie. Okay, so it contains some key information. One is the description and the scope, and I think one of the things we need to really sort of be mindful of here is this covers not just our NHS services, but also our adult social care services. And I think we need to sort of maybe have a little bit of a think about how we socialise this wider amongst some of our social care colleagues as well. But I think that's really important to know. It's not just a health thing. The next one, Julie. So there's information there on the timescales, and I've got to say the timescales I think are quite ambitious, particularly when we've got suppliers who are having to develop functionality, then test it, and then deliver it. But I think the really important thing about this is we start the journey and we start capturing the information, and then we try and sort of adhere to these timescales as much as we possibly can. But the 2 key dates we're working to really are phase 1, which is around that local implementation and local recording on your systems. Trying to get that in place by March next year, and then starting to look at the digital integration and the digital sharing of that information, so it it can go wider than just your organisation into June next year. Next one, Julie. And then, as we've already sort of touched on, the ISN contains pretty much majority of the SNOMED codes that you and your suppliers will need. I've just put a little bit of an example there. In terms, just a word on SNOMED codes, these really are things that you ideally want hidden away behind you know, the user front end. In most cases, you don't want your users to be, you know, having to input or see SNOMED code. You really want them in their systems to be seeing the human narrative there. That makes a lot more sense to, you know, to clinicians and to our sort of service users as well. The SNOMED codes are really important though. We, you know, ideally want to keep them hidden away in the background, but the significance of them is they are a computer code that then is really easy to match up between different organizations and different computer systems and the central spine. So those codes are really the things that, you know, unambiguously then allow us to match up and share this data. I think what you'll find at the moment is a lot of people may be recording information around reasonable adjustments in their systems, but it's not being coded in that SNOMED code, and that's what's going to make it then really difficult to try and reconcile and share that information. So, you know, one of the key things we need to start doing is thinking about how we implement the codes if they're not already there in your system, or how we start, you know, migrating away from what we might have recorded locally without those SNOMED codes and starting to adopt and map towards those codes. Next slide. Okay, so in terms of what needs to be recorded, the ISN document gives you a lot of technical information, but in a sort of sense, going back to that sort of wireframe, what it might look like for a clinician. Effectively, what we're recording is the consent to share information, which is, you know, again, really key, because this is what's going to enable us to either sort of keep that information locally if that's what somebody wishes, or to be able to share that with other parts of the health and social care system if that's, again, what someone wants. Again, there are SNOMED codes for that, as Hannah's pointed out. They won't be in the ISN at the moment, but they are available, and we can sort of supply them if needed for suppliers. They're actually on there's a national database of SNOMED codes you can go and look up, and they're actually on there now. They've been, you know, published and delivered out there. So we capture that consent once per patient. Then we can actually go on and record as many adjustments that are needed for the individual. So there's something called an impairment category. Our focus today really is on the learning disability codes, but there are, you know, other categories that can be picked up there as well. Then within that category, there's a subset of codes that can be captured for different needs and different adjustments. There's also a free text narrative that can be captured, which is really good. So we're not, you know, trying to pigeonhole people into very specific codes. If someone has a particular, you know, real need, or there's a different, you know, you need to put a bit of supplementary information in there about an individual, and there is that ability to put that free text narrative in. There is the ability as well to put a complete, you know, bespoke adjustment in if you've got somebody who has a very, very specific, you know, need or an issue that we need to sort of capture information on. Again, there's a SNOMED code to say this is a bespoke adjustment, but then the majority of that message is carried in free text, and all of that is, again, on the spine, so that can be exchanged between local systems and the information on the spine to be shared with others. If you want to try and conceptualize what it looks like, it's very difficult when you read the ISNs and you sort of see all this text. I've put a link on the bottom there. This has been implemented already on the National Care Record Service, which is a sort of national web page. You can go and view and record this information and put it onto the spine now. So that, you know, the functionality is live. It is there. You can go and have a look and see what it looks like. So there's a link at the bottom there which will take you through to some of the sort of training type material for NCRS, just if you want to have a look and try and visualize what it's like. I've also tried to be clever like Hannah and put some QR codes on there, so if you're whizzy and scan that with your phone and go and have a look at it from there as well. But when the slides come out, you can click on the link and just go and have a look and see what it might look like. Next one. Okay, I'm not going to go too deep into this, so don't worry. So we've got the ISN, which defines what this is, what information needs to be collected, and all the codes and all of that sort of thing. This is already built up on the national spine, so if you look at NCRS, you can go there and see if anyone's got reasonable adjustments recorded nationally. You can update and enter that if you've got the rights to do so. but that information sort of sat away from your current clinical information system. So we need a way really of joining those two things together. So your local system and your local recording with the national system without you having to, as a clinician, having to jump out of your system that you use on a day-to-day basis and jump off into another system and go and find, you know, the person you're working with and update it. And that's where this technical thing called an API comes in, or an application programming interface. So this is a bit of techie code that allows one system to talk to another system and effectively transmit information between the two systems. So there are different ways you can interact with the API. You can go and read it, which is a sort of GET API, and you can put information up there as well and write information and update it also. Like I say, I'm not going to go deep onto the APIs. There's actually quite a bit of information there on the NHS Digital website. Again, I'll put the links in the QR code, but that's really something you need to direct your information and technical people towards, and your system suppliers towards, to go and have a look at that. The APIs are in what they call alpha state at the moment, which means they're still being developed. But I'll sort of cover that a little bit when we get onto the national update. But it's hoped by early next year they'll move into what they call a production status, which means they're pretty stable and up and running and ready for day-to-day use. Next slide. So just give you a bit of an update on what's happening nationally, because there is some national work going on to try and help tie all this together. So there is a central NHS England NHS Digital team working on the development of those APIs, and obviously that includes testing, because we need to make sure these things work and work correctly. They are developing something called a bulk upload facility. So we're aware now that there's systems that have probably captured reasonable adjustment information, and people will be implementing this over the next few months before the central APIs are fully ready. So what's being developed is a facility, again, that sort of technical people and system suppliers can use to take any information that you've recorded locally and be able to upload and reconcile that with the national spine. So you can sort of do a one-off synchronization of your system, if you like, before you then switch on those APIs. Once you've switched on your APIs, you should then be working, in a sort of real-time live situation with that central spine, and that bulk upload wouldn't be repeated again. It was really just a bit of a one-off facility to enable you to sync up and get ready for that live exchange of data. It's a really good positive bit of work, that bulk upload, because that's something that wasn't being talked about a little while ago, but they've committed some development around that, which is really good. And the central team are also working with a couple of suppliers, and obviously it's not an exhaustive list of every supplier out there, but these are the suppliers who've said they're willing to put a bit of development time and development resource in to work with the central team to try and implement these APIs, find out where there might be problems. So these are the ones who've been willing to put a bit of extra resource in to do the testing, in some cases a bit of rework of these things. So the suppliers that are being worked with directly are an organisation called Medical Director, who are one of the new entrant GP systems, so that they haven't got a live site at the moment, but they're quite a significant partner because they're doing the development work with the central team and testing that out. EMIS are working with the central team, both their GP and community systems, and as we heard, the Access Group, who develop REO, the mental health system and community system in some parts of the country, they're working with them in quite a bit of detail as well. So they're sort of working through the testing of these APIs. TPP for System 1 are engaged, but they're not currently sort of developing out the APIs, but it's not saying they're not cited on this work. It's just they're sort of working with the other providers who are doing more of the detailed testing work. The central team will support other suppliers on request. So if, again, locally in your organisation, if you've got a system supplier who's sort of struggling or they're not quite sure how to implement this, there is, again, a central team support they can go to and have a chat to people. So before we jump onto that one, Julie, I was just going to say this is really very much about the development of that API and the information sharing. As Hannah said, there is some local work that can be done within systems now to start capturing this information, and particularly the GP systems, because they handle SNOMED codes pretty well now already. So there is work being done across EMIS and TPP System 1 to develop the use of those SNOMED codes, put them into templates so they're visible, and that information can start being captured now. The idea is once you capture that information, you'll then do that bulk upload to the spine, and then when the APIs are switched on, you'll then be in that live sort of situation. So I guess there's a sort of path through the primary care systems to capture this information, sync it, and then start using the APIs. When we look at trust systems, there's probably a slightly different process that needs to be driven through with each organisation. Next slide. Just a quick word about there was a little bit of a limitation on these APIs that would have caused us some difficulty. So when they originally developed the specification and the API, there was a requirement to have a smart card basically in the system and be authenticated before you could actually view or update the information on the spine. A number of areas, including the North East, we flagged this as an issue because not all systems and services currently use smart cards. So a good example is the Badgernet maternity system in this region. The supplier is really keen to develop against the APIs, but they don't use smart cards. So that was a pretty much showstopper for them. Because of the way shared care records work, things like the Great North Care Record, you don't log onto it directly, you log onto your local system, and then you jump to Great North Care Record, and there's what's called a trust relationship between the two. Because you haven't got that direct connection, it would have prevented reasonable adjustment information being available in things like the shared care record if we had that smart card restriction in place. And it also limits the potential for the automated use of reasonable adjustment. I think we're very much focused at the moment around the capturing of this information, but I think we need to also think about how we really put this into use so we make those adjustments. One thing that's possible in the future is we could automate some of the processes that we have at the moment to take into account those reasonable adjustment flags. So for example, if you have a system that's churning out appointment letters as an automated process, there's no reason why that system couldn't read the flag and understand that perhaps someone needs that information in a more accessible format and actually honour that requirement automatically and process that accordingly. Similarly with things like appointment allocation, if you've got a scheduling system and somebody's needs an afternoon appointment, there's no reason why appointment allocation systems couldn't pick that up if they can go and automatically read the reasonable adjustment flag. So there's some of the limitations that would have really been in place, but the good news is the central teams have actually been really good on this, and they've agreed to put in place what's called system-to-system authentication. So it doesn't weaken the security in any way, but it enables these things to start happening there that would have been a limitation before. So they're actually starting that development in the new year, which is a really positive step. Next slide. Okay, so in terms of the sort of next steps for organisations in terms of technical implementation, I think we probably need to think that sort of the two different groups. We've got primary care, which has probably got a slightly different path to going live, which I sort of talked through in terms of systems that are used in other places. So things like foundation trust, community, emergency departments, things like that. Probably the key message is for to work with your IT departments and your digital departments locally. Speak to system suppliers, just make sure they're actually aware of the information standards, notice straight away, and then ask them for what their implementation plans and timescales are, both for that phase 1 and phase 2. I think that's then going to really help drive your local plan for implementation. But in essence, what you need to then do is look and review any current reasonable adjustment recording that you've got on your systems and try and work out how that gets aligned to the new SNOMED codes, because that's without those SNOMED codes in the background, you're going to really struggle to exchange that information. There's then the need to implement the new codes as part of phase 1, so by March next year, and then making sure that we try and make sure that the reasonable adjustment information is visible and communicated as much as possible. And the means we have at the moment, which may be, make sure it's put onto things like any referral templates to other agencies. And again, being quite mindful here that it might be other agencies involved with the individual and social care, or perhaps even the third sector, and not necessarily just other health partners. And then moving into next year, as the APIs move into this production status and become available and stable, it's starting to think through that digital integration around how we may need to do those bulk uploads of any information we've captured, and then switching on the API, so we move into that really good position where we're starting to share that information real time between organizations. Okay, last slide, I think, is on the next one. Yeah. This is obviously going to take time to work through, particularly the digital integration part. I've not actually totted it up, but we must probably have about 50 or 60 systems in the region where, you know, we need different organisations to go and try and get this implemented. So that's a lot of work with a lot of different suppliers, and they're not going to all do it on time. So one of the things we are looking at is working with the Great North Care Record team in the Northeast to see if we can bring down that reasonable adjustment flag from the spine and display it on the Great North Care Record. So, you know, we have a lot of our systems in the region already connected to Great North Care Record, and if we can display and surface the reasonable adjustment information through that, it's again a good interim step whilst the organisations individually are working through all of this with their different suppliers. That work is dependent on these changes that the national team are doing to the API to enable this system-to-system authentication, but hopefully that'll be in place, you know, by the spring next year. And the Great North Care Record team are, you know, already sighted on this and working actively with the supplier to see if we can get this up and running. We haven't got a lot of resource in the region, unfortunately, to support this, and particularly on the digital side. But I'm happy to offer a little bit of, you know, support to any local organisation, foundation, trusts who are trying to sort of work this through with their suppliers. I've already met a couple of trusts and just again gone through this in a little bit more detail, and I can get into some of the real techie nuts and bolts if anyone wants to. But I'm happy to have some discussions if it helps, and just get people set on the right track and moving in the right direction with this. And I think that's it. Hope that wasn't too technical. So just open to questions now.
Thanks very much, Darren, for that, and for the offer as well to have those conversations with organisations individually. So if people feel that is going to be helpful, then please get in touch with Darren directly or put a note in the chat and we can take it from there and link it through. So I'll go through the chat first of all to look for any of the questions in the chat. So if you just bear with me at the moment. Ashley, you've got a couple of questions. I think the first one was around SNOMED code. So the links to the SNOMED codes have been added. So then you've got a question. Will it be measured? Will ICB report on it? Will there be targets? I don't know if you want to ask that question specifically, put a bit more detail to it.
Yeah, that's fine. I've had early discussions with Julie regarding this, and in Sunderland we're thinking about actually including it in our quality premium incentive just as a starter to get the ball rolling. But that's something we kind of want to do. But I was just wondering, what is the thoughts? Is it going to be part of the contract? Are they going to have to, you know, achieve a certain percentage by this time next year? Just a bit more information about that, really, please.
So from a national level perspective, at the moment, there are no quantitative levels of things that you will have to achieve for numbers, because it's more about showing you have systems, and that is what would be judged and assessed. And it is likely to be part of national assessments from points of view of things like CQC assessments. We'd have to see that you have your systems in place and that it's running correctly. Because it's mandated under the Health and Social Care Act, it's not going to be specified specifically in contract, because actually it is part of your legal
what
contract.
Should be doing, yeah.
Exactly, yeah. So it's sort of all part and parcel of the same thing. So one of the questions I frequently get asked from a kind of a GP perspective is, will it be in QOF? No, because it's not a specific GP thing, it's absolutely everyone. So it is less about the pure numbers, although we will be looking obviously at how many people are uploading, just so we can see where there are problems, where there are issues, what we can do to help and support that. But more about show me you're working, really, rather than anything else. Great. So I think that sounds like a brilliant idea, Ashley. I love that. I think that's a fabulous idea.
We haven't got it through yet, but we've got a meeting next week, so I'm going to do my best to push it.
Fantastic. Well, good luck. Sounds like a really sensible idea.
And could I say, if anyone else on the call wants to talk to Ashley about how she's doing that and trying to get that into the quality improvement framework, then let me know and I'll link you through to Ashley. If that's okay, Ashley.
Yeah, of course.
I'm just going through the questions. Joe, when reasonable adjustment codes have successfully been embedded in the Ardens template for learning disabilities, will the ICB let us know? For people with autism or neurological conditions, would it be appropriate to add their codes to the records? So is this for a specific group only?
So I'll take that if that's okay. So so as I say, talking to the very lovely Rob, who is the CEO for Ardens, his feeling is that the reasonable adjustment box or launching to the reasonable adjustment specific template is pretty much needed on every single template of every single long-term condition or review that you do, because whilst this is clearly, as I mentioned before, started with the Learning Disability and Autism Directorate, it's for a quarter of the population of the UK. So I think the estimated numbers of people that would meet the Equality Act definition for at least being entitled to reasonable adjustment should they wish is 13.8 million people. That's not clearly just for those with learning disability. So it will be in the LD template, and he is going to make amendments for that bit, but it's also going to be in all of them. From the point of view of the actual template, it's because the codes for the reasonable adjustments, there's about 400 and something odd codes. So embedding that within a separate template itself becomes impossible to see. So there will be a separate reasonable adjustment template, which you'll be able to load, a bit like their communications and accessibility one now. But as Darren brilliantly mentioned, which is completely correct, the number of codes that we can have is infinite, but the more codes you put onto a template or a usability system, it just, you know, you could have millions. I mean, how would you know which way to start? So one of the most useful things I think is probably going to be the bespoke one. From the point of view of unusual requirements, I've got a patient, for instance, who can only access healthcare if she's got a teddy bear under each arm. There's clearly no SNOMED code for that, but it is absolutely essential. The codes that are really important to code will be the ones that require automated systems like easy read information or things in a large font. And it's for appointments. We're linking with the screening programs. We're linking in with everything so that try and automate that system so that we can improve the screening uptake for people whose reasonable adjustments are preventing access, that kind of thing as well. So the answer of will it be just those people for people with autism or neurological conditions, absolutely everyone that would meet the Equality Act definition, which is someone who has a significant impairment or disability that is likely to last for 12 months or more. So you don't need a diagnosis. You don't have to have any of that on the system, and you also don't need to share that if the patient doesn't want their impairments to be shared. You just need to know what the adjustments are. So from the NHS long-term plan requirement for all people with learning disability or autism as a diagnosis, in other words, if you're an autistic person, to have a flag on their records, that's a slightly different NHS long-term plan requirement, but it clearly is linked. But for this perspective, if you think someone has a reasonable adjustment, whatever template you're using, whatever codes you've got on, if you can get that reasonable adjustments required and their adjustments on that system, then it will share through once we're linked in. Sorry, does that answer your question, Ashley? Was it Ashley? Sorry.
No, it
Joe,
wasn't
sorry,
Ashley.
Joe. Sorry, Joe. Did that answer your question, Joe?
Yes, it does answer the question.
All right, lovely. Thanks.
Great. We'll take this one from that's in the chat from Ashley, then I'll come over to Kathy. So Ashley again is asking about, is there any instructions for bulk uploading? Because Sunderland have already got a significant number of patients recorded with their reasonable adjustments. So Darren, I don't know if that's one that you can help with.
Yeah, I've popped something in the chat there just to sort of emphasise that the functionality is just being developed now, but what it will be dependent on is looking for those SNOMED codes in the GP records, and importantly the consent code, because if there's no consent code there, it won't get picked up and pushed into the central spine.
Right, so the problem, yeah. Sorry.
This way, it's really important to sort of get through the template work that Hannah mentioned. And if there's an incomplete template, I guess there without any consent, that information won't go up. So that there's probably some data quality work that might be necessary just to make sure we've got sort of good, complete, and up-to-date record, so they then can be bulk uploaded. I'm not expert on GP system, but I also understand that if you don't capture that information through bulk update, the next time you access that person's record, if you update that information, it'll do a check with the spine once the APIs are live, and just basically sort of make you aware that, you know, there's information you can either push up or pull down from the spine. I think it'll work the same way that, you know, something like a change to someone's demographic, you know, details such as an address would happen. So again, it's not a one-off opportunity with the bulk update, but it's just really to try and help, you know, get any good quality information that is in the GP systems or other systems up the spine.
Yeah, that's absolutely spot on. So the purpose of the bulk upload is that, as you so brilliantly say, there's loads of people who've got reasonable adjustments recorded for many, many, many years. And if we can get the consent then applied to their records, all of that will upload, whether you see them in the next 6 months or not. But obviously then when you do see someone, if you've ever used GP systems, you'll know if there's a difference in the spine from what address or phone number you've got recorded compared to what the spine has. So you've got yours, the spine have got theirs. You get a flash up on your system to say there's a difference. It's on the PDS, the patient demographic service. It'll ask you which one's correct. It's a similar system to that. So it'll say, we've got nothing on the spine about reasonable adjustments, but you seem to have some on yours. Which one do you want to use? And clearly you'll click, I'd like to upload the reasonable adjustments, as long as you've got that consent, and it'll go up and go down. So when you're in a record, once the APIs are live, that will happen all the time. The benefit of the bulk upload is that it doesn't require you to access each person one at a time. It'll do it all in one go, which is great when you've so much historical data already recorded.
Great, thank you for that. Kathy, and then I'll come over to Pam.
I'm just seeing there's a really good question in the chat from Elizabeth. Is there a risk if someone hasn't got capacity to consent to the reasonable adjustment that won't happen? Now, I'm presuming that we will be doing these sorts of things in the best interest of the patient.
So yeah, so it is. So it's
that you had best interest decision. Yeah,
absolutely. So like all decisions, it'll be done on best interest decision. So it's a capacitor's decision. So if you have capacity and you can give or decline consent, if not, then it's a best interest decision, just like it would be for anything else. And the ability to record that consent has been given under best interests is built in within the system. And clearly that in the vast majority of cases, vast majority of cases, it will be in the patient's best interest to share that reasonable adjustment information if they can't consent. There will be very few occasions where there isn't, but the legal teams were absolutely insistent on us having this bit in. So yeah, so that's why that's there.
No, I think that's really key. I put it in the chat that I think there's a sort of a vague list of people that you might consider reasonable adjustments in. So I've put that in the list in the chat. That's part of the prevention of adult not brought work that Kirsty and I did to try and scope out who might need it. And I think there's something about capacity and fluctuating capacity in there that I think is really, really key. And those people who are 16 plus but not 18, so sort of sit nicely in that transition age, but don't really sit nicely in any sort of easy system. I wanted to say something about the fact that these things are a conversation, and I think the other thing we need to capture as systems and as practitioners and as teams, we all just make that reasonable adjustment, don't we? And we don't really think about it. Primary care is all about making bespoke appointments, I think, for lots of patients, and I think that there will be a job in actually just pulling back and trying to be a bit objective and thinking, actually, what are we already doing for this person? What's in that appointment setting that we haven't captured for other people? So I think that conversation is really key, but also just that thought process. Thank you for that,
said.
Darren.
Yeah, definitely. Pamela, you've got your hand up there.
Hello, can you hear me okay?
Yeah.
Thank you, everybody. That's been so interesting. I mean, I'm a governor at Northumbria, and you know, we always, well, at least I in particular, feel there's almost like a disconnection between the NHS Foundation and the mental health, and that there seems to be somewhat of a you know, there just isn't that necessarily connection there, and I think it's quite disappointing, because sometimes I think patients feel very uncomfortable when they, for instance, just go to Centex, you know, the main hospital there, and I don't think they get the care that they require, because people have a lack of understanding, and I still think it happens today, and I must admit I have actually been on about it. But I think the actual systems that are in place, which looks as though hopefully they will also connect with Northumbria records to have all that information, would be absolutely fantastic. But what I think would be very, very appropriate, and Darren, you could probably organise this, that it would be very, very good to have this sort of thing over to the governors at Northumbria and give them an insight to the mental health side of things, and how perhaps there should be perhaps a little bit more of a connection. I mean, for instance, if someone is pretty bad, say in Centec, and perhaps need to go to a ward, rather than go there, perhaps there should be a connection with Morpeth, who are far more equipped, if you like, with dealing with such situations. And my other concern is the length of time to actually come to a diagnosis. It's scary. I mean, in my particular case, I have an adult who's in his 70s, bless him, and he's had these problems just about all his life. He's now in a rest home, still very uncomfortable with himself. And although I filled in the forms, we're still waiting. And I think that's very, very hard, especially he's at that time of his life, but also about how long children have to wait. And, you know, I don't know whether there's going to be any improvement in that, but certainly the systems that you've shown me today are absolutely fantastic. And I think if Darren could liaise, it would be wonderful for the governors just to learn all about it.
And I saw, Darren, that you were putting your hand up to respond there, and I'll come to you as well, Hannah.
Yeah, I'll come back just on that first point. I've got to say, actually, I've worked in mental health and learning disability services. I'm digital by background for as long as I care to remember. And I've got to say, when we're actually seeing a real pull on this from our acute colleagues, which sometimes isn't always the case. Actually been really, there really is good engagement across the acute trust. And I've been working with Dave Elliott, who's the Chief Information Officer over at Northumbria, who's really good and really excited on this. So, we're just waiting for these technical building blocks to come in place. And, I think there is a real pull from, our acute colleagues. I think where they're really seeing a particular benefit on this is around some of the unscheduled care services, and obviously they want to build it into the more scheduled care services as well. But, there is really a positive pull. But I can link in with Dave, Pamela, and just sort of have a chat. And, if they want to do something with the governors, I'm happy to come along and support that. But, Northumbria are definitely engaged in it. I can give you that assurance.
And Hannah, did you have a comment as well?
Yeah, good, thanks. So I'm actually Northumbria as well. I've worked for Northumbria Primary Care, and this afternoon I'm actually presenting at the Northumbria Trust CPG. So yeah, it's I would agree completely with Darren. They are, because Jim Mackey is particularly keen on this. He thinks it's a really important thing. So it is something I would completely agree. We often see things coming down from on high, and there's a real reluctance to move, but I have yet to see anyone who doesn't think this is a good idea, and the buy-in on this is really, really key. The difference it will make is so easy to see, and the impact is massive for not an enormous amount of time per patient. Yes, getting services and systems in place is taking a lot of effort and time, but the day-to-day recording of those adjustments will take a few moments, but make an absolutely enormous difference to care and services overall. So absolutely delighted to say that Northumbria particularly are really engaged, and their CIO, their clinical CIO, as well as Dave Elliott, so Nikhil Premchand, is really into this as well, and is already putting lots and lots of changes in as well. So there's a lot of buy-in, which is good.
Excellent, thank you. Kathy, was your comment was a response as well, or can I go to Liz first?
It was, if you don't mind, Liz, you've been ever so patient. Really good to hear, Pamela, that you are involved, because it sounds like you've got a really important voice in all of this. And I think it's really, whilst it's hard to hear, it is something that we all need to hear. This work is all based on trying to achieve parity of esteem for patients with a mental health problem in the physical health system, and we're not there yet. I'm happy to have a conversation with you outside of this, Pamela, if that would be helpful, because I've done a lot of work on how we do this and how we make patients' experience better in this setting. And Hannah and I work really closely on the systems behind the reasonable adjustment flag, because the flag's one thing, but actually how do we operationalise that for patients and for carers and for families? And that's a whole other ballgame, as Hannah has alluded to. There's a lot of joint working going across the ICB now, so that's health social care. I can't think of any of the other partners now because I've had a menopausal moment. However, we are working as a system to try and make this better, and that is happening across the region, and it's also happening in Northumbria. So there is a lot of work going on. So I don't want you to think that this is a hopeless case that's never going to get better.
Excellent. Thank you for that, Kathy. Liz, I'm aware you've been sat very patiently. Thank you.
That's okay. It's just going back to the consent question that I posed. I'm absolutely. I work in the acute trust, and this is, you know, brilliant. This is music to my ears. But I have worked for many years trying to get organisations to share information. I do have access to System 1, and what I find repeatedly, even when I know that the person doesn't have capacity to have given that consent, that consent to not sharing information is repeatedly being put on the system so we can't see the information. And my concern with this is that the consent will be used as a reason for not putting in the reasonable adjustments, because that is the easiest option. Just press one button and then we don't need to do any more. And that's my big concern. And absolutely, we should be using best interest. But my concern is that, very like System 1, it won't be.
So I think the first thing I would say with System 1 is that the share in, share out portals are a pain in the backside, and yeah, so often its default is not share, so you have to turn it on to share. So it's, yeah, and I would have to say that quite a lot of the time it is not clear at all whether from our end whether there's any share in or share out. So from a GP end, you can't see if you've shared in, shared out unless you go into the node, which, you know, so it's not brilliantly designed. From the consent perspective, it's a really important point. Thank you. I think the key there is that a consent is agreed to share on the flag, and it's really explicit in the standard that if the person declines to share on the flag, you are still under law required to ask and put reasonable adjustments in place in your local setting. So not having consent to share on the flag doesn't get you out of the requirement to do the reasonable adjustments locally. So all you're doing is making a rod for your back by not sharing on the flag, frankly, and that's the message that I probably would find a slightly better way of saying, but essentially say that, which is, look, you're going to have to do it locally. You have to by law. If you were to share that, or consent to be shared, to ensure that you are requiring and obtaining consent where appropriate to share that, then you're actually reducing your workload for future contacts, because otherwise when that person comes back, you're going to have to do the whole thing all over again. So I think the key bit is not to think of that no consent means you don't have to. No consent just means not on the spine, but it doesn't mean you can't do it locally. You still have to do it locally, all of it, every time, rather than just take somebody else's work down the spine.
And I think this is key when we're talking about the education and the training that needs to come alongside this, that these are some of the points, the conversations that need to come out of that.
And it's certainly in the e-learning, it very specifically says that. It very specifically says, if you don't want to do other on the spine, that's fine, but you still have to do it all locally. Because I think that message is definitely, but that's one I've heard lots of before. And I think it's a very, really, really key important point. So thank you.
Excellent. Pam, I can see you've got your hand up still, Pamela. I'm not sure if that's still from previously or whether you had another question. Oh, excellent. So Kathy, over to you.
Thank you, Julie. I think the other thing we need to think about is people who have unrecognised conditions. So people with suspected autism, suspected learning disability, people who you just know they need a reasonable adjustments, but you can't really quite work out why. You've made a really good point, Hannah and Darren, about this not needing to be a diagnosis-led thing, but I think we need to be proactive in all of the settings that we work in about, you know, this person, whatever's going on, they need a reasonable adjustment, and to be proactive about doing that. And in that, we might recognise more people with a learning disability and autistic people, because we're still nowhere near the prevalence that we think we should have. I think it also helps us recognise those people who are on the way to dementia, those delirious people, those people who you just, so I had a patient the other day, I've known him for 20 odd years. This is mortifying. I can't believe I'm saying it in such a massive forum. He's had a severe mental illness and substance misuse for a long, long time. And I just had a light bulb moment in the practice. Oh my God, he's had a learning disability all this time, and I haven't recognised. So I think it helped me that Sarah Barnard, the learning disability nurse, was with me sitting in. However, I think there's something about us actually being open to the idea that someone needs a reasonable adjustment that we hadn't realised, and we have a number of vulnerable people who do not have access to our services. They find our services extremely hard to reach, and if we can meet some of their needs, I think that would really, really help. So have your eyes open for those patients who just haven't quite worked out what's going on, but they might be the people that benefit from this the most.
Excellent, thank you for that. Kathy, Hannah, you've got your hand up.
Simply just to, yes, thank you, to absolutely reiterate that really key point, which is this is not diagnosis led. You can enter the diagnosis on the flag should the patient wish that to be done, and that often will provide context to the reasonable adjustment, but absolutely it is based on adjustments. And one of the ways to prevent some of the potential stigma concerns is that every patient should be asked if they have reasonable adjustments. Don't assume they don't. Don't assume that they do. The question is, do you have any reasonable adjustments? And if that patient doesn't, then that's fine, you can move on. But it should be that we are asking, in the same way that we're checking name, date of birth and address for everyone, we should also be checking if they need reasonable adjustments. Clearly not in those words, because if you don't know what those words mean, but I mean, what I mean is that we should be asking everybody, then we're not presuming, we're not stigmatizing, and we're not missing the people that potentially are the most vulnerable, i.e. those that don't know that they need.
Thanks, Kathy. Darren?
Yeah, just something I guess a little bit of work that's going on in the background, but we haven't talked about too much here, is once this information is starting to be captured and built up, we can, I guess, do some reporting off the back of that. So this isn't about getting you all, big brotherish and trying to work out who's recording and who isn't. But, we have an opportunity, I guess, to try and, from a population health point of view, just trying to understand where, we're applying the code appropriately and where it's not, and look at sort of consistency as well. And, we have things like learning disability registers on GP systems. So, we could sort of do some matching across that and just try and understand, where there might be, areas of really good practice and where other areas may need more support. Like I say, it's not trying to get, all big brother around that, but actually just trying to, help with that level of consistent recording. So I think that will be a real challenge. This is a huge task. But, the better the coverage and the consistency we can get, obviously, the more we can make those adjustments that people need.
And we've had some conversations about that with Radar around can they put some flags in the system so that they can identify those individuals. And again, it is not so that we can look negatively on places where there aren't a large number of people recording reasonable adjustments. It's so that we can go in and understand what the challenges they are having are and put in place support to help them understand that process, maybe offer that training, that education to help a particular organisation really think clearly about reasonable adjustments in the flag. So that's sort of longer term, once things are embedded. So it'll be later on into next year that we're starting to think about how we can start to support those organisations who are maybe struggling a little. Pam, you've got your hand up again, Pamela. Oh no, hand's gone down. Okay. I haven't picked up any of the questions out of the chat that haven't been answered or an offer of an individual conversation. Ashley?
Not sure if the response from Darren was for me or somebody else. I was just trying to establish where we've already recorded on Ardens with an annual health check template that somebody has agreed to share their information with third parties. Does that constitute the consent to be able to bulk upload or not? Would they still need to be asked that question again? because I think you've answered as Hannah in a later comment when you said it's got to be very specific to the reasonable adjustment flag.
Unfortunately, from a pure legal perspective, it needs to be specific for that flag. One of the ways that we're doing it is contacting those that have given that consent to share for SCR, for example, and just saying this flag is now available, brief explanation of what it is. Are you happy for us also to share on that? And I have to be honest, so far we've had 100% yes, but I think then you can prove from a legal perspective that you have complied with the legal bits and pieces. Yes, long conversations with lawyers about that.
Thank you.
Okay, so do we have any other questions from any of the members in the room? Okay, so I'm just going to share one last slide, which is our next steps. Oop. No, I'm not. I'm going to go right to the beginning of the slide deck. Let's stop that. Sec. Okay. Final slide to share. Just wanted to highlight for people what we're thinking in the North East and North Cumbria are our next steps and things that really give you an opportunity to learn more or understand more about the flag. There is obviously a lot of stuff going on in the background, and we're really keen to keep people as up to date as possible in what's happening. So when we started this work, we made a commitment to doing a 6-monthly face-to-face event. Our next event is towards the end of January, 26th of January. It's in Newcastle, and if that is something that you would be interested in, there is a registration form to complete. The link is there. We will have limited places because it is a face-to-face event, but we intentionally have it as face-to-face because the reasonable adjustments flag work links in with a lot of experts with lived experience, and it is far easier for them to engage with a face-to-face event than it is on a Teams event like this. So we are actively bringing in the experts by experience who've been supporting this work so that they can explain some of the work in the background that they're doing as well. Alongside, there'll be updates on a whole range of other topic areas and making sure people know what's been happening nationally and locally. So that's one thing that's coming up. We also have a Digital Champions Masterclass that's happening in February, 15th of February. That's with the Health Inclusion Network, the former Academic Health Science Network. They have a large number of digital champions across the Health Inclusion Network. So that masterclass is specifically for them. But if within your organisations you have any digital champions who you would like to signpost towards that masterclass, you're very welcome to share that information with them. It is being supported by Redmore Health, and so the link there is through to register with them on that email. Questions and answers from today we will pop onto the website. That may take a couple of days just to go back through the recording and make sure that we've got all of the questions and answers, particularly those that have been asked verbally during the session, but they'll go onto the website, and when that happens I will just send out an email to everybody who has attended with a link to the recording and to where the question and answers are on the website, so everybody will get that. I've got nothing else to add at the moment other than thank you very much as ever to Darren and to Hannah, who as always have been amazing in making information seem far more understandable than I'm able to do. It is a real privilege to be able to work on this project. Personally, I think it is going to be able to change a massive number of people's lives. And this is the hard bit at the moment, getting it embedded and getting things in place. And it is going to take all of us just chipping away to make that happen. But thank you very much, Hannah. Thank you, Darren. If there's any final questions or comments, please put your hand up now, or if Darren or Hannah have got any final comments, then please just chip in.
Not for me, just a big thank you to everyone. Thanks for your time.
Yeah, ditto, just a thank you. And I love the fact that most of the comments down the right side are this is exciting, this is exciting. I think that's exactly the right word. This has been a long time coming, a lot of evidence behind it, and it'll hopefully make the difference that we really ought to have been having in place for the last 13 years finally happen.
Brilliant. Okay, thank you very much, everybody. Enjoy the rest of your Friday. Hope you all have lovely weekends planned. And any questions, please just